Good evening, one and all. At the outset, I would like to thank Dr. Prashant for inviting me and giving me this opportunity. So in the next 15 to 20 minutes, I'm going to discuss about the endobronchial obstruction in thoracic malignancy. Otherwise can be named as central airway obstruction, central malignant airway obstruction. So we are going to discuss about the following points: why we do worry about central airway obstruction, what is the disease spectrum and what is the classification, what are the clinical implications, and what is the role of an interventional pulmonologist in this aspect. So why we worry about central airway obstruction? We all know that lung cancer accounts for 8 to 10% of the all cancers in as far as India is concerned, and worldwide it is almost 12 to 14%, almost number 2 cancer worldwide. Significant proportion of these lung cancer patients can develop central airway obstruction at some point of time during the natural course of the disease. Almost 40% of the deaths are due to locoregional disease, locoregional extension, and endobronchial involvement. More than 50% of the lung cancers are not resectable at the time of diagnosis itself. So we know that. So almost 20 to 30% of the patients develop complications of complete or partial airway obstruction. So this makes the significance of the central airway obstruction and this thing. So as I said, almost 20 to 30% of the lung cancer cases present with central airway obstruction. So the central airway comprises of the trachea, both the main bronchi and the proximal lobar bronchi also. So the area which is marked here comprises the central airway. So central airway obstruction is a significant proportion of the lung cancer patients we face with. So what are the clinical impact these two have? Whenever a patient has a malignant airway obstruction, the patient can have dyspnea. The dyspnea may be a progressive, progressive exertional dyspnea to a sudden onset acute airway, maybe because of massive bleed from the tumor or sudden obstruction by the tumor itself. It can cause massive bleed and hemoptysis. They can present with atelectasis. Beyond the point of obstruction, patient can develop obstruction, the atelectasis of the lung, and post-obstruction pneumonia. And sometimes, as I told, because of massive bleed or the tumor itself can cause asphyxia and sudden death. When the tumor presents purely endoluminal, the problem again happens because the diagnosis itself is getting delayed, because most of these patients will have very minimal symptoms, or they will have wheezes, and also they are misdiagnosed as asthmatics, and they are treated for longer period, especially when the chest X-ray is normal with a small endobronchial tumor. So they are misdiagnosed as asthma and diagnosis delayed. So we need to be more vigilant, and more CT scans has to be done to pick up this central airway obstruction. And symptoms, as again told, the symptoms are very slow. Sometimes when the tumor is obstructing more than 50% of the luminally, patient get significant dyspnea and all. For an exertional dyspnea, tracheal diameter should become less than 8 mm. So almost till the 8 mm trachea, patient can breathe normally and may not present to you the symptoms. And for rest dyspnea, the tracheal diameter may be less than 5 mm. And the symptoms does not depend on the size of the tumor, extent of the tumor also. It depends on various determinant factors from the patient side also. Length and pressure across the tube which is obstructed. The peripheral obstruction may not have much symptoms. When there is a central obstruction, a very large tumor may have symptoms early. And ability to create negative intrathoracic pressure. So patient's ability to create negative intrathoracic pressure, which is again dependent on the patient's general performance status, pulmonary reserve and comorbid conditions, and cancer cachexia. So these are all the determining factors of the symptoms, not only the tumor alone. When it comes to the spectrum of the diseases, it can be a primary lung tumor which is invading the airway, or it can be a compression from the mediastinal tumor or an esophageal tumor which can compress the airway and present to you with an obstruction, or it can be a primary airway malignancy like adenoid cystic or mucoepidermal carcinoma, or it can be a metastatic cancer commonly from breast, renal, and colorectal cancers can present to you with the central airway obstruction, or sometimes a mediastinal lymph node can erode into the airway and present as a central airway obstruction. So when you classify them, it can be a purely endoluminal tumor which is present only in the lumen, which is not outside which is not present outside, or it can be a tumor which is present presenting in the which is present in the mediastinum and compressing the airway. It's not involving or it's not invading the mucosa. It's only purely compression, or it can be both. So it can arise from the peribronchial or peritracheal area and invade the bronchus and present as a mixed growth here. So there can be an endoluminal, purely endoluminal component or a mixed component. Treatment depends on the location and size of the tumor. So here is a case, a 60-year-old female, shortness of breath, cough, and hemoptysis for a month's duration. She presents with stridor on presentation. More dyspnea on right lateral positions. You can see the CT clearly. There is a tumor arising from the lower part of the trachea and extending to the left main bronchus, completely occluding the left main bronchus and extending to the trachea also. The proximal part extends to the trachea and partially occluding the left main bronchus. When you do bronchoscopy, you can see clearly the tumor is extending from the left, completely occluding the left main bronchus and involving the carina also. So that's the tumor which is present there. The large tumor which is completely occluding the left main. Other patient, 30-year-old male, shortness of breath, cough for 6 months duration, classically presented with V's, treated as asthma. So X-ray showed a little lower airway, lower tracheal narrowing. So he had a PFT which showed a typical truncation of the inspiratory and expiratory limb. So large airways obstruction was suspected. CT confirmed a lower tracheal tumor. And this is the bronchoscopic picture of this particular tumor. You can see here, occluding the trachea almost more than 80%. This is another patient, a 70-year-old male, long-standing neck mass from thyroid, which has suddenly increased in size, and patient became breathless and presents with stridor to the ER. The thyroid mass, which has got a retrosternal extension and compressing the trachea. The CT clearly shows that there is a obstruction from the external compression. So how do we approach these patients? So these patients, as I told, basically they can present with the progressive dyspnea or some other symptoms. Patient may be stable at this time of presentation and one extreme. And the other extreme, patient can present to your emergency with an acute airway because of either a complete obstruction by the tumor or by massive bleed or something. So the initial workup is dictated by the patient's clinical presentation and the stability. It can present as an acute airway with tumor obstruction or hemoptysis. And so these are all the investigations we can do, but chest X-ray as an initial investigation, which can show less information about the tumor when it's present endobronchially. Sometimes it can help you to lateralize the lesion when it presents with a lung parenchymal involvement or a collapse or atelectasis. And mediastinal widening can tell you that there is a tumor presenting there in them and compressing on the airway. So CT will be more appropriate and more accurate. And we can get detailed information about the tumor, extent of the tumor, level of obstruction, and we can get more information for the interventional workup also. For example, important location of the tumor from the important landmarks like vocal cord and carina. For example, if you're going to do a stenting, then probably you need more information from the CT scan. PFT is usually done in only stable patients. So reduced peak expiratory flow, and as we have shown here, truncation of inspiratory and expiratory limbs can be typically seen in central airway obstruction. Diagnostic bronchoscopy confirms the diagnosis. It can give you more information about the tumor, which can differentiate from the secretions and necrosis. CT scan can sometimes overestimate the tumor obstruction because of secretions may mimic like tumor, or necrotic tissue or bleed may mimic tumor, and CT scan sometimes overestimate the obstruction, but bronchoscopy can clearly differentiate that tumor and secretions and necrotic tissue also. And advantage of bronchoscopy is simultaneously you can do a biopsy. That you should need to be very careful in manipulating these tumors in central airway obstruction. If you are doing flexible bronchoscopy, then probably a simple manipulation with the biopsy, forceps, or touching the tumor may induce a bleed, or edema can suddenly lead to complete obstruction and present and make the stable patient as an acute airway. And sometimes the drugs used for bronchoscopy, like sedatives and neuromuscular blocking agents, can detrimentally affect the patient's breathing and ventilation, and can lead to acute airway. So you need to be very careful in flexible bronchoscopy in these patients. Coming to the therapeutic bronchoscopy. So why we should intervene these patients? Because these patients have symptoms. Basically, they present with dyspnea, and the dyspnea is significant. And if you do something like a debulking the tumor, then you can dramatically change the patient's symptomatology, and the patient can improve dramatically from the dyspnea and all those things. And of course, atelectasis and obstruction pneumonia can complicate the issue, so it can be avoided. And of course, the patient presents with bleed, then probably he needs something to be done to control the bleed. And on the other hand, these patients, though they have poor survival, and your bronchoscopic intervention may not change the survival much, but the quality of life definitely changes after you do something for the patient. For example, a debulking of the tumor from the central airway can dramatically change the patient's dyspnea, and patient can have a good quality of life until he survives. And probably it can combine with chemotherapy and another modality of treatment, so that you can extend the survival. And again, your surgical treatment or chemotherapy or other modalities may have a very slow effect on the tumor. I mean, on the tumor which is acutely presenting as central airway obstruction. So you need to do something bronchoscopically to relieve the symptoms. What does the literature say? A lot of evidences from literature also say that long-term quality of life, long-term quality of life for the central airway obstruction patients who are undergone a therapeutic bronchoscopic procedure has improved. So this paper from Thoracic recently said that therapeutic bronchoscopy results in 5.8% improvement in the health-related quality of life, which is roughly about 1.5 times the benefits seen in the malignant pleural effusions patients who had undergone some treatment for malignant pleural effusion. Again, here, survival and quality of life benefit after endoscopic management of malignant central airway obstruction. This paper showed that interventional management of patients with malignant central airway obstruction may achieve prolonged survival with sustained significant improvement of quality of life. So clearly, we can see that improvement in quality of life, though the survival benefit may not be absolutely seen, until the patient survive, they may have good quality of life. The timely airway stenting improves the survival in patients with malignant central airway obstruction. Again, another paper. So the management depends on the classification. So basically, if you have an extraluminal obstruction, extraluminal component alone, there is no pure endoluminal component at all, then probably you have dilatation. You can go with the balloon dilatation and stenting. So there's no other choice. Since there is no mucosal involvement, you cannot do anything on the mucosal aspect. So you have to do a stenting and come back. On the other hand, if there is endoluminal extension of the extraluminal tumor, or if there is a purely endoluminal component, then probably you can go and do something for these patients. Either you can go for a laser or organ plasma electrocautery or cryo spray or cryo debulking, all those things. So you can mechanically debulk also. So you can debulk the tumor by using various modalities, including your thermal hot and cold allergy therapies, or you can go for delayed effect therapies like brachytherapy and photodynamic therapy also. And sometimes you can have a stenting also after debulking the tumor if the airway is unstable post debulking. And generally, these are all very high risk procedures, has to be done meticulously in either operating rooms or in your bronchoscope suite, provided if you have a good backup with the cardiothoracic surgery backup and all those things. And you should be aware that you are always sharing the airway with the anesthetist here. And you have to decide whether we have to do the procedure into flexible bronchoscope under conscious sedation, or you have to go for the rigid bronchoscope. So you have to choose accordingly based on your backup and based on your resources. And you have to have a pakka pre-procedural planning, and it's always going to be a teamwork. So most of the interventional procedures, like in central airway obstruction, is going to be with the rigid bronchoscope, because rigid bronchoscope has got a lot of advantages that you can simultaneously ventilate the patient and do introduce various accessories into the lumen and do the procedure simultaneously. in the central airway obstruction. Whereas flexible bronchoscopy, the vision is very poor, and loss of airway is more possible with the flexible bronchoscopy alone. Once you lose the airway, it's very difficult to re-establish the airway if you don't have rigid bronchoscopy backup at the backup. But only advantage is you can approach peripheral. So more peripheral tumors you can approach with the flexible bronchoscope. So recanalization techniques, as I told, it can be mechanical coring from the rigid bronchoscopy barrel itself, or you can use laser, argon plasma, or electrocautery. So these are all hot thermal devices. You can use cold energy by cryo, and you can put silicon stents and metallic stents depending on the situation. So these are the basic recanalization techniques. Here we can see some of the examples. So this patient who presented with a tumor in the lower trachea with a small pedicle, large tumor with a small pedicle attached to the posterior wall of the trachea. So you can clearly see that adrenaline is being injected in the pedicle, and can use a snare, electrocautery snare, to hold this tumor completely, engulf the tumor. The snare is being introduced. Thanks to Dr. Prashant. So this is Dr. Prashant's video, basically, Mr. Prashant's patient. So electrocautery snare can engulf the tumor completely, and you can, I think the video is, okay. Yeah. So basically electrocautery is the contact thermal energy. Unipolar cauteries are basically commonly used, and there are coagulation and cutting modes available. And the flip side is you cannot have control over this. When you're using a snare, it's not difficult, but when you're using a cautery knife and all those things, it can have chances of airway perforation. So this is argon plasma coagulation, wherein the APC probe is introduced through flexible bronchoscope, used to achieve more of a hemostasis. So the tumor is debulked, there's a lot of bleeding from the tumor surface or tumor bed. You can spray APC over the tumor bed to control the bleed. So basically it is a non-contact thermal energy. Argon gas is used, and you can have a controlled depth of penetration here, and it is more useful for hemostasis. Chance of perforation is less here. So you can see that reasonably good hemostasis achieved after spraying APC over the tumor bed. The mechanical coring and stenting. The rigid bronchoscope barrel can be used as a mechanical instrument to core out the tissue. So this is after clearing the basic tumor from the mid-trachea. The rigid bronchoscope barrel is used to core through the tumor tissue, and after debulking, since the airway was very unstable, the stent was placed in the mid-trachea and at the end of the procedure. You can see that at the end of the stenting here. Cryotherapy. Cryo used as a cold energy, carbon dioxide or nitrogen used as a cold energy gases. So the tissue is freezed up to minus 90 degrees Celsius to cause cell necrosis, cell death. So delayed necrosis and healing happens with the cryo. You can extract the tissue immediately with the cryo probe, or you can use cryo probe for cryo ablation. You can leave the tissue after application of cryo, and it gets necrosed and later gets expelled off. So this is an example of cryo here. You can see that.
Dr. Santha sir, some fast.
Yeah, sure. 2 minutes. I'll just skip off this video. So basically, you can use multi-modality approach. You can use all the hard therapies, cold therapies in a single patient to achieve a good tumor debulking and hemostasis. Basically, this video tells that. So basically, central airway tumor, the patient is symptomatic. You have to decide on whether the endobronchial component is there or extrinsic component is there. Based on that, you have to decide. So for an immediate effect, you can use mechanical debulking, thermocoagulation, or cryo debulking. To maintain the effect, to maintain the airway patent, you can put a stent and come back. For a delayed effect, you can use cryo, radiotherapy, or brachytherapy. If there is an extrinsic compression, if for immediate effect, you can put a stent and come back. For a delayed effect, you can go for a radiotherapy and all. To summarize, malignant central airway obstruction can significantly impact the patient's quality of life and their eligibility for systemic therapies. In trained hands, bronchoscopic interventions can provide minimal invasive options and restore the patency of the airway and provide a good quality of life. Multiple tools are available, as we saw, so to utilize through bronchoscopy. So bronchoscopic debulking offers a synergistic action in combination with other modalities like chemo and radiation to enhance the patient's survival. Thank you for the patient attention.
Thank you. So we'll take question and answer later.
Sure.
So now I'd like to invite Dr. Riya Shah. She will speak on malignant pleural effusion. Where are we now? And she is a clinical associate at Lung Care and Sleep Center,